Steffel welcome Jan to report on the non-vitamin K oral anticoagulants. Thank you. Just to remember, I think you can have all the recorded talks on cardioletter.ch at noon are available then.
Excellent. Thank you very much, Giovanni. Thank you, everybody for showing up this early in the morning. It's always difficult after our social event, and then if there's the Euro and soccer, even though Germany didn't really play that well yesterday, I guess some of us at least stayed up late. This is my disclosure statement for giving you an update on the new novel oral anticoagulants, the non-vitamin K oral anticoagulants, what's new in 2016, and I actually chose to give a little bit of an overview over things that are not necessarily completely new to 2016, but that may also be interesting and important for our daily clinical practice. And I'll start out with one of those slides that we always say as a disclaimer, you shouldn't show them this way, and then we all do show them this way, but I think I only showed this for one reason. What you see here is the different studies that have been performed with the NOACs, the Bigatran, Rely, Rocket AF, Rivaroxaban, Aristotle, Apixaban, and the ENGAGE study with edoxaban. And the one thing that one shouldn't do, obviously, is when you show a slide like this to cross-compare these trials. And I'm only showing one endpoint because you know the study data anyhow. They've been out for a long time. I'm just showing the all-cause mortality endpoint because I think this is something that really sticks to one's mind. If you take into consideration, these have been 4 different trials, completely independently conducted, different patients, different drugs, yet they all come out in a way the same. At least there is a trend, or in some cases even statistical significance, for a benefit in mortality. And this is the same for intracranial hemorrhage. It's very similar for very severe types of bleedings, life-threatening bleedings, fatal bleedings. They're all on the left-hand side of the 1.0 line. So they're all going towards a benefit for the NOACs. And I know this is nothing new for 2016, but it's something to keep in mind also for 2016, because at the end of the day, if you want to, you could say that not only there's a mortality benefit for the NOACs, you could turn this around and say there is a signal for an increased mortality if I put my patient now, 2016, on a vitamin K antagonist for anticoagulation of atrial fibrillation. So really standard therapy for anticoagulation this year and next year likely as well, is with one of the NOACs. What else is new? To supplement these clinical trial data, we are increasingly surfacing the real-world data. And the one thing that I don't like about the real-life term that we're using here, and I'm using it myself, but the one thing that I don't like, because it makes you wonder whether the patients in a clinical trial are not from this world. I mean, they're from this world as well, right? So this is not really real world in a sense that we're now talking about the real people and we didn't have real people before. However, the one thing that it's supposed to mean is that we're more talking about the patients that we're seeing in our daily clinical practice instead of the ones that were really strictly chosen with very stringent inclusion and exclusion criteria in the clinical trials. However, we should be cautious in interpreting these data because also real-life evidence data, real-life patients, real-life data derived from these patients are prone to some bias. There is a selection bias, actually the single bias that we have every single time when we prescribe these drugs in our practice, in our hospitals. You know, some over-under reporting of events is possible, of course. And again, we're talking about patients that for the one or the other reason are selected to receive the one or the other drug or no anticoagulation at all. And there are several types of real-world data that are out there. This is not the most recent one, but really to supplement the whole idea here. This is from the 2014 FDA analysis on dabigatran. And what you can see here on the left-hand column, this is the dabigatran event rate for these events, for these outcomes. And this is the warfarin rate right here and the adjusted hazard ratio. And suffice it to say that the outcomes of this FDA analysis were really very consistent with the RELY trial, so with the randomized trial. As you can see, there's less ischemic stroke, there's much less intracranial hemorrhage, there's more GI bleeding, which is interesting because it sort of also gives a little bit of a validity to those data. It's really exactly the same as with the high dose of dabigatran in the trial. There's less myocardial infarction. As you remember, there was sort of a signal in the RELY trial, there was less myocardial infarction, and there's less mortality. Again, with all the precautions that we have to take into consideration for this real-world data, this is very reassuring. For rivaroxaban, we actually have a prospective real-world study on the use of and the use, safety, and efficacy of rivaroxaban in the real world. This is the Xanthus study. This has been published last year, and this actually, suffice it to say, again, I'm not going too much into detail, is that the results of this trial, of this real-world observational study, a prospective study, were very consistent with the ROCKET-AF trial. Similarly, and this has only just been presented, it's not yet published, the Revisit US data is actually, it's a claims database based data that has surfaced. It's just been presented a couple of weeks ago, 1 or 2 months ago, and also here, as you can see, intracranial hemorrhage, ischemic stroke, and the combination of the two, all of them are landing on the left-hand side. Very consistent with what we're seeing, or what we've seen in the ROCKET-AF study. Personally, I feel this is the main message that one can derive from these real-world data. The data are consistent. I personally would not interpret too much else into this, but this is already very important. And finally, something that's also just for now only been shown as a poster. Last year at ESC, we're still waiting for the publication, is the market scan data for apixaban. And as you can see here, patients on warfarin, patients on apixaban, and now here they only reported bleeding. They did not report on ischemic stroke, but for the bleeding, even if you adjust for baseline variables in a Cox analysis, you come out with much less major bleeding. So in summary, for the real-world data, what one can say is there's really no signal so far that has been surfacing that what we've seen in the clinical trials, as I've shown in the first slide, there's no signal that this is not true in the real world. So we don't have a signal for an increased hazard. We don't have a signal for an increased bleeding from everything that's been published so far. And again, some of the precautions, many of those real-world studies, especially this one and the one before, are not yet published, so we're waiting for the publication, not only for the presentation. One thing, and this I know this is not really too much 2016, this has actually been a while since this has been published, but something that I'm seeing today more and more is how different scoring systems are being used and in fact are being abused. And one of those scores that in my view is being abused is the Hasbled score. So the Hasbled score, as you remember, has been introduced into the guidelines to sort of assess or give us a little bit an idea how to gauge people's bleeding risk. And I think it makes a lot of sense for that because there are a lot of factors in the Hasbled score that are modifiable. And these modifiable factors we need to aim for. Every time we see our patients, we need to take a look at hypertension. Is it controlled? Is it non-controlled? We need to look at INRs. Are they well controlled or not? If they're not well controlled, maybe a patient to be switched to a NOAC if you don't want to switch him anyhow. But it's been abused in a way that patients with a high Hasbled score are, on a general basis, denied oral anticoagulation. And this is not what it's for. As a matter of fact, that's not what it was for to be introduced in the first place. And it's very interesting because CHA2DS2-VASc score and Hasbled score, so ischemic risk for these patients and bleeding risk, they track along extremely well. So patients with a higher CHA2DS2-VASc score usually also have a higher Hasbled score and vice versa. And this Danish study, and this is only one study, there's actually a second one from Sweden that goes into a very similar direction. They took a look at the net clinical benefit that patients derive with different CHA2DS2-VASc scores and different Hasbled scores. And what you can see here is patients with different CHA2DS2-VASc scores, 0, 1, and then 2 to 9, with an Hasbled score of 2 or less. And I don't want to go too much into detail with the drugs, but take a look at this subgroup because that's the one that's most important. Obviously, CHA2DS2-VASc score 2 to 9. There's a good benefit for all the NOACs and also for warfarin. Net clinical benefit out of ischemic stroke and intracranial hemorrhage. Now, keep this picture in mind when we go to the patients with a Hasbled score of 3 or more. And again, this subgroup right here, CHA2DS2-VASc score 2 to 9, there's also a net clinical benefit. And in fact, if you compare this to the slide before, the net clinical benefit is actually even bigger. Paradoxically, because this is with a higher Hasbled score than we saw before. But that's exactly for the reasons that we said. Patients with a high Hasbled score usually also have a high CHA2DS2-VASc score. And in terms of net clinical benefit, they don't profit the same. They actually even profit more of anticoagulation because in general, their CHA2DS2-VASc score is higher. So Hasbled score is a good score. It's a good score to remind us of what to look at in patients in order to reduce their bleeding risk, but it should not be used as a sole measure to deprive somebody of anticoagulation who otherwise would qualify for it. What else is new? The direct antagonists, the direct antagonists are underway, and as a matter of fact, iduricizumab for dabigatran has already been is already available in Switzerland and across Europe and in the States as well. Just to get everybody again on the same page, iduricizumab is a monoclonal antibody. Dabigatran usually cleaves factor 2A, which then, inhibits factor 2A, so inhibits fibrinogen cleavage. The iduricizumab is a monoclonal antibody that binds dabigatran and hence allows for coagulation to occur again. This is the reverse AD study that's been published last year, and as you can see, as you know, this was a 2-arm study. It was both patients with bleeding events and patients undergoing surgery. And in both arms, literally Group A and Group B, once these patients were on dabigatran, once they were giving the antidote, it immediately dropped down to a normal level of coagulation. So really, as with the onset of the infusion with the onset of the dose of the drug, you have a sustained effect, which then came back like 12-24 hours afterwards. It came up again if there was still dabigatran on board. So a very immediate effect, a very direct, very specific effect, and without any prothrombotic effect, which is really positive. And this was the dilute thrombin time that we saw right here, and this is the concentration of unbound dabigatran. So immediately after the first dosage, there's really nothing ongoing anymore. For factor Xa inhibitors, they're a little bit behind, but not by far. Andexanet alpha will hopefully be available next year, maybe by the time next year even, likely in summer, fall. It's the andexanet alpha that is furthest advanced, and andexanet alpha works a little bit differently than the antibody. It's actually not an antibody, it's a protein. It's actually a factor Xa decoy. So you picture factor Xa right here, and the andexanet alpha, they look very similar, except that one amino acid is exchanged, and as a result of that, this molecule is enzymatically not active, so it does not cleave prothrombin into thrombin. However, it still has the same binding site for factor Xa inhibitors, and it's a universal factor Xa antagonist, so it binds every single factor Xa inhibitor. So what happens, obviously, if you give this to the patient, is that factor Xa inhibitors, this binds free factor Xa inhibitors, but it has no enzymatic activity, so true factor Xa gets available for coagulation. And this is the Annexa A with apixaban and the Annexa R with rivaroxaban study that was published in the same article that was last year in New England. And as you can see, there's several ways of giving this. You can either give it as a bolus, or you can give it as a bolus plus an infusion. And the effect that you can see is if you give a bolus, you get down with factor Xa activity immediately after giving it, but factor Xa activity then resurfaces and gets to the same level as if you were not giving the drug anymore. This is placebo, and this is the infusion of the antagonist. And this is true for both for apixaban and for rivaroxaban. Now, if you follow this bolus with an infusion, you get a very sustained effect, very nice and sustained effect. So this also seems to be working very well. And again, we will likely have this, this is just around the corner, we will have this next year, middle towards the end of next year available. I wanted to also lose a couple of words on something else that is very important in our our day and age, 2016, that's LAA occlusion. I think we have a good way of protecting patients that are not eligible for anticoagulation. As you know, the left atrial appendage is a source of thrombi, and this is certainly one of the messages that the PROTECT-AF trial has shown us. This is from this is now 2 years ago, where actually there was a mortality benefit in the long-term follow-up of these patients. These are not very many patients, to be honest, but it's a device trial. They usually don't have the same amount of patients as drug trials. However, just one word of caution with these data. This is again from the same paper, the PROTECT-AF long-term data. As you can see, the main benefit from these patients is from the reduction in hemorrhagic stroke. You have the device group right here with a rate of 0.2 versus 1.1 in the warfarin group, so a clear superiority with respect to hemorrhagic stroke. With respect to ischemic stroke, there's really not much. And as a matter of fact, numerically, even have more ischemic stroke, or a higher ischemic stroke rate in the device group than in the warfarin group. And if you take a look at the causes of mortality, the only one that comes out significant really for the device group is hemorrhagic stroke. All the others, there's really no big difference, there's no big effect. So actually a very similar picture to what we're seeing with the NOACs. Also, NOACs have a mortality benefit in terms of ischemic stroke. They're pretty similar. The bigatran had a bit of an edge. The rest is very similar, or at least not statistically significant with respect to warfarin. The main advantage, the main driver of mortality is the reduction in bleeding as compared to warfarin. And if you take a look at the PREVAIL data, this was a sort of a sister study of the PROTECT-AF. And that was demanded by the FDA back then for approval of the Watchman. Also here you can see in the June 2014 analysis of the PREVAIL trial, ischemic stroke, 13 patients in the Watchman group, 1 single patient in the control group. Mind you, this was a 2-to-1 randomization, so this is only half the patients randomized. However, a very similar trend that's emerging here. And this is likely not device-related thrombi, although in some cases we see that. It just shows you that the left atrial appendage does play a role in terms of stroke for atrial fibrillation. However, it also shows us, and to be honest with you, this is one of the biggest things that these two trials established, because at that point in time, we really only had indirect evidence for that. So for the first time, we're seeing that the left atrial appendage actually plays an important role for stroke and atrial fibrillation. However, what these studies also show us is that it's not the whole story. There's more to ischemic stroke, there's more to stroke, and there's more to mortality for patients with atrial fibrillation. Atrial fibrillation has to be considered a systemic disease. And as a systemic disease, standard therapy for that is systemic. And particularly in patients that are not eligible for anticoagulation, these patients will be good candidates for LAA occlusion. With respect to everything else, we will have to do the trials. We will have to compare this to NOACs. We will have to see if we have to add any additional therapy to that in the long-term course of these patients, and to which patients, in order to protect them in the right way. So, Mr. Chairman, ladies and gentlemen, my summary and my take-home message: number one, NOACs in 2016 are standard therapy for stroke prevention. You have to find a good reason to give somebody vitamin K antagonist instead of NOACs. NOACs are recommended in the guidelines as a standard therapy, and we've seen the data why this is so. The real-world data that are emerging, and there's a lot of them emerging, the good news is they are very consistent with the trials. Everything else, in my personal view, is over-interpreting these real-world data. There's a lot of confounders also here. The good news is we really don't have any major signal so far that there's anything that we should be concerned about. Net clinical benefit matters for patients. It's not only the reduction in stroke, it's also the reduction in bleeding. And for us cardiologists, this is something we've seen for ages. Usually, if we decrease patients' ischemic rates, like in ACS, like in PCI, be it what it is, we usually buy in on more bleeding. We don't for the NOACs. So this seems to be a very good, a very good balance between efficacy and safety. At the end of the day, this is what patients need. Direct antagonists are available for dabigatran, iduricizumab, or are just around the corner, and this is for the 10A inhibitors. And again, this is good and this is helpful. However, most importantly, I think, and this is something we've been stressing for over years now, not causing a bleed or not having a bleed is likely more important than having a direct antagonist. So the argument, we're keeping our patients on vitamin K antagonists because we have a direct, fast-acting antagonist, which we don't, does not work. We need to prevent bleedings in the first place. That's more important than having the antagonists. And finally, LAA occluders are a good option. In 2016, these therapies have arrived in mainstream therapy, and that's good because it's a good method and it's good for a lot of patients, particularly for the ones that are contraindicated for anticoagulation. Standard therapy, and that brings me back to the first line, is anticoagulation in 2016. Thank you very much for your attention.